Now we move on to item number 7, which is to receive the annual report relating to HIV/AIDS.
Thank you, Supervisor Yeager. Dr. Sarah Lewis will make some comments about the written report that you have in your packet. Dr. Lewis is our STD HIV controller who's been with the county for about 2 years and has led the effort in helping to implement all the work to prevent HIV and STD and get the Getting to Zero effort organized and off the ground. And I would also like to mention that Dr. Lewis is something of a YouTube star from her STD screening video. So if you've not seen Dr. Lewis starring on YouTube, I encourage you to have a look.
I have not seen that, but
well,
I look forward to seeing it.
All right. Dr. Lewis.
Thank you, Dr. Cody. And thank you, Mr. Chairman. Thank you, Supervisors Sumitian, for the opportunity. I'm very proud to have a chance to present this report to all of you and highlight the really incredible work being done across the county in the prevention and treatment of HIV and AIDS. In May, I was in front of this committee talking about a very different picture with other sexually transmitted infections, where we're seeing rising rates and rising numbers of complications. But the picture here with HIV is a much more positive picture. We've actually seen a stabilization of the HIV epidemic in this county really for almost a decade now. In the number of new diagnoses, we've had roughly stable numbers for about 10 years. And the slight uptick we saw last year from the year before actually also comes with an increase in the percentage of late diagnoses, which may suggest that some of our efforts to increase testing has actually been successful in finding some people who've been living with HIV for quite some time and unaware of their diagnosis. We've also seen persistent improvement in life expectancy and improvement in every arm of the HIV treatment cascade, improvement in people aware of their diagnosis, linked to HIV care, and virologically suppressed. These advancements haven't been equally distributed, though. We do continue to see disproportionate impact of HIV upon LGBTQ communities, upon people of color, people experiencing poverty and homelessness. And so these are the greatest reminders to me that our work is far from done, that we don't just need to sustain the improvements we've had so far, but still have a lot more to do. And I think there are 3 main reasons that I'm able to report this positive epidemiology of HIV in the county. I think these are in part due to global scientific advancements, but then to the local collaboration we have here in the county, and then mostly to the sustained county commitment and prioritization of HIV and the communities affected by HIV. We see these scientific advancements really in the areas of the wide range of safer treatments now available, so that people diagnosed today with HIV have multiple options that can allow them to achieve virologic suppression and in fact have the same life expectancy as somebody not living with HIV. We also know those people, when they become virologically suppressed, have actually 0 chance of transmitting HIV sexually to their partners, or what we refer to as undetectable equals untransmissible. And then finally, we have PrEP, a daily pill that is incredibly safe and incredibly effective at preventing HIV. But none of these advancements mean anything if we can't get them to the community, and that's what Santa Clara County has done so well. We actually have a long history of leveraging federal resources such as Ryan White funds and state funding to create wraparound services for people living with HIV and ensure they have everything they need to access treatment. And then also use additional funding to access testing and outreach and education. But there were gaps in this network, and that was what was picked up on by the county and championed by Supervisor Yeager, and prompted even stronger support in 2016 when the Board of Supervisors funded the Getting to Zero initiative, with the goals of 0 new HIV infections, 0 HIV-related deaths, and 0 HIV-related stigma. And it's this additional booster into the gaps that we had in our existing systems that have allowed us to leverage those existing relationships we already had and really jumpstart very fast-paced progress in a number of areas in HIV prevention and care. And so going forward, with all of these moving parts of various funding streams and more than 50 collaborators between county departments and non-county community organizations, we have 5 main areas that we've been working to improve and that I report to you on our progress in today. Quality and usability of collected data, PrEP and PEP access, HIV and STD testing and integration of services, linkage and retention in HIV care, and HIV education and reduction of related stigma. And I think the continued work to be able to keep doing what we're doing and doing it well, to extend the benefits we've already seen and to make sure there's no backsliding, I think we'll need sustained and predictable resources for the work we do, clear communication and continued commitment of all of the county players and community collaborators we have. And then unfettered modern data streams that allow us to keep measuring where we are with respect to the epidemic, how we're serving the communities we care for, and how the work we're doing is actually playing out for those communities. So with that, thank you for the opportunity to present the report to you, and I'd happy to take any questions.
Well, thank you. I do have a number of questions and comments, and after we delve into this a little bit, I'm going to have the people who are here that are working on this issue come forward and say their name and their position, so we can all thank them for the very hard work that they all do every day. I guess, and I'll call you Sarah if that's okay, Dr. Lewis. First off, you're doing a wonderful job. Dr. Cody, a great hire, a great position that we funded, and I know that you are making a huge difference in this, and we keep on sort of giving you more challenges that you have to work through, but I'm glad we've been able to give you the staff that is needed. I agree with everything that you said as far as the progress that has been made on many fronts, medical progress as well. But on a lot of these issues that I'll go into in a second, a lot of it comes down to the individual and his or her relationship with their clinic, their primary care physician, or the person that they have contact with. I think it's still a societal issue that that people are hesitant to talk about their sexual behavior. We know from the LGBTQ health assessment, many gay people don't tell their primary doc that they're gay, and so that important conversation never happens. And I think what we're all trying to do is work with certainly our own medical people as well as the private docs to make HIV testing just natural. Just don't even ask, just say, oh, and then we're including this. How well are we doing with sort of getting people tested? And we put a lot of resources into doing it, but I'm wondering if that message is being received particularly by the private docs.
That's a great question. I think to your first question, how well are we doing? I think we have some signals that we're doing better than we used to be. Some of the findings with the increased number of diagnoses, lower percentages of people unaware of their HIV diagnosis that we draw from a study at the state level, tells us that more testing is happening, and we know that it's happening more often in primary care settings and not just in isolated HIV testing opportunities, although those continue to be important. But a couple of things that we're doing, we know that there are still gaps exactly as you described, and we pick up on these gaps in a couple of key ways. One is by our novel provider detailing campaign, where we send expert health educators out into community clinics to talk to providers, either because we are aware that they're diagnosing HIV and STDs and may need additional resources, or we notice a gap that they're not diagnosing anything, and we know that that's likely suggesting a missed opportunity to care for their patients.
So you get that information, and then we'll send people out there to double check to make sure that
exactly
they need more information,
right.
or understand the importance.
Exactly. Whatever it is they need, whether it's practice conducting respectful and open sexual history taking, whether they need to understand new elements of how testing can be performed or paid for, or whether they need technology to assist them in things like pepper prep order sets that make this easier for the client as well as for the provider.
That's great. So that's sort of one step that's involved, and it's great that we're doing more mobile testing as well. Certainly, the easier you can make people have the HIV test, the better off it is. So I'm glad we're seeing more of that. Then the next thing, of course, is for people who are negative to get them on Truvada if that would be appropriate for them. And I know that in the early days, I think even before you arrived, there was a lot of skepticism, a lot of ignorance, not much acceptance for Truvada, and so that then took a lot of one-on-one conversations with not only the patients, but also with the primary care doc. Could you talk about how that's doing, and are we making progress, and are doctors feeling more comfortable in prescribing Truvada, and then also trying to figure out how the insurance companies or the county might try to cover those costs?
Mm-hmm. Excellent question. So to the first part about how we're doing, we have a couple of signals that that uptake by providers, willingness to provide this service and do it well, is improving. Some of that, again, comes from one-on-one feedback during our provider detailing sessions. Another is that the Please Prep Me website, where anyone can go and look up where's the nearest doctor who can offer me PrEP, has had increasing numbers of providers willing to list themselves as not just only willing to give PrEP, but maybe even an expert or somebody willing to recruit new clients to their care for the ability to access PrEP. At the same time, we do still hear reticence. We do still hear about clients who come to our PrEP navigation service who had a missed opportunity at another provider and described to us, it was recommended that PrEP wasn't going to help me or it may not be safe. And so we're able to then take that feedback through our PrEP navigation system, pass it on to either myself to do a provider training or our health educator to do outreach in that setting, and really respond directly to that concern that we're hearing. And then additionally, we're doing a wide number through the Getting to Zero PrEP Action Team, a wide number of trainings for providers, either in web versions, in person, going into doctors' offices, doing grand rounds, to make sure we're changing minds with providers and showing them not only how safe and effective PrEP is, but how easy and rewarding it is to provide that kind of care for your clients.
So those are for the patients who test negative.
Mm-hmm.
Then we have the patients who test positive. And at that point, too, again, if somebody has health insurance, hopefully they'll be able to get on the antiretrovirals so that they can have a suppressed virus. But what about people who don't have that access, and trying to make sure that they understand the medicine that they need to take and how they have to take it on a regular basis, and trying to keep track of that they're in retention as far as their care?
So one of the things that is now a widespread practice nationally, but was done, some of the earliest practice was here in Santa Clara County, was the development of what we call the Positive Connections team, who are linkage to care experts. So their job is the second somebody has a new HIV diagnosis, they're met one-to-one, sometimes even the day they receive their HIV test result, and really have their hand held through not only the emotional journey of understanding they have a new disease and figuring out what they need to remain healthy and keep their partners healthy, but understand all of the resources we have in the county. This is everything from housing support and case management, essentially free access to care. No one is ever denied access to HIV treatment because of cost reasons, legal support, housing support. So really wraparound services for somebody living with HIV to make that transition when they become diagnosed and understand that they have everything they need to be able to access medicine and stay on that medicine.
And I know that all these things that we've talked about takes a great deal of staff time.
It's what we do all day, every day.
What you do all day, and we're soon will actually see the faces of the people that are sort of doing this one-on-one work. But then the last part of all of this is public awareness of HIV, of getting to zero, of trying to reduce the stigma, and which is, of course, the whole idea behind the campaign for getting to zero. Mm-hmm. Could you talk a little bit about how effective we're being in that regard? And that I've also looked at the charts, the age group with the highest HIV infections are in that 20 to 29 year group. It seems like the other age groups much less, but that's still that target we have to hit. Mm-hmm. And every year you get a whole new cohort of people who become sexually active as they become older and get teenagers and sort of move on. So you almost have to start from the beginning with them because they just wouldn't have all that background. But if you could talk a little bit about how we're targeting younger people so that we can keep them not getting infected.
So that actually, I think that specific goal of making sure the general population are really aware of what HIV looks like today and all the opportunity that they have to prevent HIV or thrive if they have an HIV infection is some of what the Getting to Zero funding has been most powerful to do in a couple of novel ways. I think, for example, our social marketing outreach, which has been specifically talking about PrEP, but which has had a lot of collateral impact in terms of letting people know in general the changing HIV landscape, has been really impressive. And we actually received a report yesterday that while the report to you describes through the end of June how many, I think we had 13 million views of our latest PrEP social marketing campaign, we're actually at 45 million as of the end of the campaign last week. So we are really getting in the faces of the youth to let them know HIV has changed, and therefore the stigma related to it really should melt away as you understand you have the power to protect yourself and to thrive if you have the infection. We also need to start even younger than that 20 to 29 age group, and so a lot of the work we're doing is to improve sex ed in the county. And we're fortunate in California to have the California Healthy Youth Act, which requires that sex ed in public schools includes open, respectful conversations about people of all sexualities, of all genders, explicit information around PrEP and how effective and safe it is, and really the most up-to-date, scientifically accurate sexual health information. But a lot of schools didn't have the resources to make those changes to the most up-to-date and most beneficial curricula. And so again, we're doing work to support, to bring curriculum to schools in the county and then to support parents' nights or school boards or administrators, whatever they need to make the change really happen in their schools. And I think that's where that really early education in what HIV means today is going to have the most impact as people leave school and become those 20 to 29-year-olds at risk.
Dr. Cody, do you have the resources that we need? Are there gaps that we need to fill as far as the overall program that we've initiated?
I think that with the support that we've had from the board to our program, that we've very effectively filled in the gaps. And most importantly, I think that we now have right people in right seats, and we're far more efficient. We also have fantastic partnerships with many of the people that are going to come and introduce themselves shortly. So I think for the moment, we're in good shape. Thank you so much.
Supervisors Median, any questions?
That being said, our numbers are essentially flat with minor fluctuations over the last 3 or 4 years, yes?
Are you referring to new HIV diagnoses?
I am, yes.
So in the report, I don't have the numbers as well as Sarah does, but they were up and then down and then up again. You have to tease out differences in reporting. So for example, the more aggressive we are to get people to test, the more cases that we're going to find. And so as Sarah mentioned, that even though we had more new HIV diagnoses in 2017, more of those were late diagnoses. In other words, people that we now have identified that we might not have before had we not increased screening, if that makes sense. So
it does. Let me ask the question that Supervisor Yeager asked, but in a slightly different way, which is, understanding that it's a complicated and challenging set of issues, that there's a sort of system-wide effort to try and address those challenges. What's the single most important thing we could do over the next 2 to 5 years to drive those numbers down? Lots of different things so if you said, all right, and I'm hoping this isn't going to be the answer, or are those numbers not going to go down in spite of our best efforts? Because that's really what I'm trying to push.
So I'm too much of an optimist to say that we can't do better. We absolutely can, and when I say getting to zero, I literally mean 0 new infections. I think the most powerful thing we actually know we can do now that we understand that somebody living with HIV with an undetectable viral load who takes their medication every day has really no risk of sexual transmission, that making sure every person with HIV is not just in care and not just prescribed medications, but able to take them every day. Now, that's obviously much more complicated than it sounds because these are real human beings with complicated lives, and it's hard for me to take a vitamin every day. So I think thinking about sustaining and even deepening that comprehensive circle of care around anyone living with HIV so that they never have a question of losing access to their medication, even if their circumstances change, and that they have the other supports they need in their life to make sure that their doctor's appointment is not an insurmountable barrier to getting their medication. Fortunately, right now we're in a setting where we have federal funding, we have some state funding that supports those systems. And so when I think about what resources we need, a lot of that depends on whether that federal or state landscape changes. But we've also instituted in the next several months a new data to care program that will allow us in real time to get names from the state of people who we don't know for sure are in care and go find those people, find out are they really in care and is there anything else they need, but if they're really not, what are they missing? And I think with that project getting up and running in the next couple of months, we'll have a better sense this time next year of the people who aren't virologically suppressed, what are we missing? What does that person need to never transmit HIV?
Thank you. Thank you, Mr. Chairman.
Thank you. You know, with so many of our programs that we create, we hire people, they go out there and do the work on a daily basis, but we actually don't often get to sort of see their faces and at least know their names. And so I asked Dr. Cody and Dr. Lewis if they could bring some of the people who work on this on a regular basis so they can come up and we can meet them. And I know she sent out the alert to the Getting to Zero Leadership, the HIV Commission, and the HIV program. And so if all of you don't mind, I'm going to have you just line up here and come up to the podium and say your name and say what your job title is so we get to learn a little bit more about who the people are that are doing this great work.
Mike Torres. I'm with the county's public health department, and I'm a health planner.
Carl Vitt. I'm with the HIV Commission.
Bob Reed. I'm with the HIV Commission. Thank you.
Vicky Contreras, Associate Management Analyst supporting the HIV Commission.
Robert Smart with the Health Trust, AIDS Services, and with the HIV Planning Commission.
Hi, I'm Marlene Bennett. I'm a member of the HIV Commission. I'm also a supervising attorney at the Law Foundation of Silicon Valley.
Hello, I'm Supriya Rao. I'm a senior analyst with the STD and HIV program, and I mainly do quality improvement work. Thank you.
Raj Gill with the Public Health Department, Health Program Specialist.
Sundar Thapalia. I'm one of the communicable disease investigators. I mostly do HIV surveillance.
I'm Elizabeth Frakes. I'm also a communicable disease investigator with the Public Health Department. Jamina Hackett, Public Health. I'm a prevention program analyst.
Rodrigo Garcia, PrEP specialist with Public Health and director of Colectivala.
My name is Candelario Franco. I'm the project manager for the Getting to Zero initiative, and I'm also serving on the HIV Commission.
Good morning. My name is Lori Osorio. I'm representing the UCSF and the AIDS Education and Training Center, and I'm also the vice chair of the HIV Planning Commission.
Well, thank you all. I'm really very proud of the work that we're doing. Yeah, I knew I was going to lose it, but it was it's so long ago, 1986, that it was the first time I ever spoke before the Board of Supervisors, I knew I was going to lose it, asking for funding, because at that point we had never funded any programs for HIV. Thank you for the Kleenex. And, you know, I just sometimes think I'm the luckiest person in the world that I've been able to work on this issue for basically the last 32 years. And from where we started, we're just panic in the streets, to really having a plan on how we can eradicate HIV. And I agree with you, I think we can get to zero. But it takes a lot of hard work, and I'm very just proud of what the county has done, what the public health has done, and really what all the people are doing on a day-to-day basis, because I think we'll get there. And with that, Supervisors meeting, we'll take a motion to approve.
So moved.
Thank you. So now we move back to item 5. This is the monthly report from the Director of the Health and Hospital System.